الكلينيكيه في اسكندريه. دكتوره ليلى كمان نائب رئيس رابطه اطباء التغذيه العلاجيه في اسكندريه، وطبعا هي كونسلتنت اوف كلينيكال نيوتريشن في مركز اسكندريه الطبي ومستشفى الشرطه. فان شاء الله يعني انجوي الليكتشر بتاع بروفيسور ليلى. اتفضلي.
اشكرك جدا، ميرسي جدا دكتور دعاء، ميرسي للحضور. مؤتمر جميل واحنا مقدرين ان اليوم has been long so we'll keep it short ان شاء الله. احنا النهارده هنتكلم على توبيك بيهمنا جدا في البراكتس عن البيري اوبراتيف نيوتريشن. عندنا شويه ايشوز كده هنتكلم فيها مع بعض. احنا انتهزنا فرصه وجود a lot of surgeons to pinpoint some of the issues that we face in this area particularly. احنا هندي introduction عن ليه النيوتريشن مع الجراحه موضوع مهم. هنتكلم عن how to assess nutrition status. هنتكلم عن certain points of how to offer pre-operative nutritional support. ازاي الاليمنتس اللي نراعيها في الانترا operative nutrition والبوست operative nutrition. طبعا كلنا عارفين ان المالنوريشد بيشنتس ايا كان الاسباب اللي هو مالنوريشد بسببها هو poor surgical candidate، لان السيرجري بطبيعه امرها causes physiological stress وبينتج عنها hypermetabolism state and catabolic response which is not favored in the malnourished patient as we all expect. Malnourished patients, once they go into surgery, they are at increased risk of post-operative complications in terms of reduced wound healing, increased infection rates, and skin breakdown. Malnourished patients undergoing surgery for gastrointestinal cancer particularly have more than 10-fold increase in morbidity. احنا في التوك الصغير ده استعنا بجايد لاينز محطوطه للجراحين واللي احنا بقينا بنمشي عليها. بيقول لنا ان nutritional status is a major determinant of outcome for any type of surgery especially for high risk patients. واحنا هنستعير الكولابوراتيف work under the name the Surgical Care and Outcomes Assessment Program Scope. وده collaboration لclinicians of hospitals across Washington state driving best practices in surgical and interventional health care. وكان عندهم initiative campaign لطيفة جدا اسمها Strong for Surgery، واحنا التشويس يعني وقع عليها في البراكتس بتاعنا علشان دي one of the easiest tools. واحنا عارفين طبعا وقت الجراحين ووقت الانستيزيولوجيست ما بيسمحش ببروسيس تكون tedious وطويلة. السترونج فور سيرجري ليها تارجتس محدده، 3 تارجتس بيمجر البري اوبراتيف البومين وهنعرف دلوقتي ليه. بيأسس النيوتريشنال ستاتس وبيوز appropriate evidence based nutritional support، وهنتكلم على السكوب اوف نيوتريشنال سبورت في مرحله البري اوبراتيف. لحد وقت قريب الاسsumption has been that a nutritional intake would positively affect changes in albumin levels. However, the American Society for Parenteral and Enteral Nutrition's ASPEN clinical guidelines advise that the albumin and pre-albumin not be used in isolation to assess nutrition status because they are fundamentally markers of inflammatory metabolism. The serum levels of some proteins under stress change during the acute phase response. Those that decrease are called negative acute phase proteins. Examples of those are the albumin and pre-albumin, and others that increase are called positive acute phase proteins, for example, the C-reactive protein. And there are many reasons to face low albumin, includes liver disease, nephrotic syndrome, inflammation, edema, sepsis, cancer, burns, and finally malnutrition. So the concept of a period of pre-operative feeding to improve the albumin level is incorrect and unachievable. واحنا عجبتنا جدا الجمله دي لان احنا طبعا countless times بنتبلغ على حالات في عنبر الجراحه والجراح كاتب لنا عايز الالبومين فوق ال3. طبعا في الاول كنا بننزعج ونتوتر، ودلوقتي الواحد صراحه بقى يعني بيبتسم لان مش على طول ده بيبقى achievable، خصوصا لان احنا عندنا زي ما ذكرنا a lot of underlying causes for hypoalbuminemia. So it's the the underlying cause of the low albumin that should be treated if possible. انما استعمال الالبومين كتارجت للسترونج فور surgery كان as a risk stratification. زي ما الالستريشن ده بيوضح، كل ما الالبومين ليفل بيقل كل ما الادفيرس اوتكمز ريتس في السيرجري بتزيد. فاستعمال الالبومين كone target من السترونج فور surgery is as risk stratification. So how do you diagnose malnutrition? Strong for Surgery recommends a nutrition screening using a pre-surgical checklist, very easy, to most accurately detect malnutrition. Patients identified as malnourished should be referred to a registered dietitian or a clinical nutritionist for nutritional assessment and intervention. This is the Strong for Surgery nutrition screening checklist. It's very easy. Just a couple of questions, mainly 4 questions, and if yes to any of these, you refer to a registered dietitian or a clinical nutritionist. And once they are identified as at risk of malnutrition or are malnourished, you refer them to the clinical nutritionist, where we apply the scope of nutrition support. Our support for patients can be in terms of just modifying food consistency or fortification of food. Then we move to introduction of oral nutritional supplements, and these come in the form of powder or drinks or puddings, and they add calories and protein to the diet. Sometimes you need a period of tube feeding if oral and oral nutritional supplements are not enough to improve calorie and protein intake preoperatively, and we can even revert to parenteral nutrition if both oral and enteral routes are not possible. If we had focused on the Strong for Surgery, the nutrition screening, they said that once indicated when preoperatively, we should use immune modulating formulas. And this immune modulating supplements, they have benefit in reducing the risk of infectious complications by 41%. And namely, the immune modulating, we have various immune modulating agents. However, most of the research was done on the arginine supplemented diets and arginine oral nutrition, containing oral nutritional supplements. So now we recognize and we are applying the nutritional protocol, the duration of preoperative support for patients at high risk. Preoperative conditioning should be applied, and this can take as long as 10 to 14 days of nutritional therapy, of course, when applicable to the surgical procedure. However, we have to note that this period of 10 to 14 days of preoperative conditioning does not necessarily have to end up with changes in serum albumin concentration or in body composition. In terms of intraoperative nutrition, we have the enhanced recovery after surgery, the ERAS protocol, pinpointing a few items relating to nutrition, as in reducing the NBO status. They allow clear fluids up to 2 hours pre-procedure. Preoperative carbohydrate loading, which we are starting to see with our surgeons. Minimally invasive surgery, and that's an important point because usually it's a difficult choice to choose the surgical procedure that will provide a metabolic load that the patient can actually handle. Minimize the use of drains, rapid reintroduction of feeding post-operatively, and early mobilization are the criteria of the ERAS. And again, we pinpoint the importance of balancing the extent of surgery with the ability of the body to deal with the metabolic load, and that's always a considerable challenge for the surgeon. In terms of post-operative nutrition, according to the ERAS, early post-operative feeding reduces post-operative complications, coupled with early mobilization to reduce the loss of muscle mass. Most surgical patients can safely tolerate an enteral diet within 24 hours of uncomplicated gastrointestinal surgery without increasing the risk of complications, even when there are more than one anastomotic site. And this is also a point of difference that we usually face with surgeons. Even though we chose to adapt or to highlight the recommendations from surgical sources, however, our ESPEN, which is the most important nutrition guidelines, published very conclusive recommendations in 2021 Clinical Nutrition and Surgery, and it does highlight and agrees with all the points that we introduced earlier in the talk. And thank you very much.
Thank you, Dr. Laila. أنا برضو of notice I need to mention here not only the guidelines of ESPEN for surgery, we have the guidelines for cancer and malnutrition in cancer, focusing on the pre-operative protocol for the major gastrointestinal surgeries. Unfortunately, إن ده على أرض الواقع مش بيتعمل غير في أماكن قليلة جدا. احنا still بنفايت مع الجراحين عشان نقدر نطبق البروتوكول ده pre اللي هو الساعتين اللي قبل no way fasting and post when to start. So the debate ده كل دكاترة التغذية اللي شغالين في المستشفيات بيعانوا برغم ان الجايد لاينز صريحة ان ده طبعا هينهاز
مش بس واضحة
واضحة وصريحة وقديمة، واحنا لسه بنفايت، واحنا كمان في مؤتمر جاسترو انترولوجي فقلنا فرصة نقول الكلمتين دول يعني علشان ان هي مش بس للسيرجري، كمان للكانسر والمالنيوتريشن والجاستروانترولوجي as a whole يعني.
Well, here is to hoping.
يعني دي point. I have another question please. حضرتك دكتورة ليلى قلتي ان حتى لو طبقنا البروتوكول اللي هو 2 weeks prior to surgery وممكن ما يحصلش ان القلب من يتصلح وممكن ما نلاقيش changes في البودي composition. So how can you assess the effect of your intervention within the 2 weeks?
Well, this is a difficult point. However, in the clinical practice, usually that just giving the appropriate amount of calories and protein for a sufficient amount of time before surgery, it increases the reserve of the metabolism of the patient, and it usually it's manifested in the labs of the total lymphocytic count, the CBC picture, the electrolyte balance. Usually that's what we look at. Even without any changes, the difference between those that receive adequate calories and protein for any given amount starting from 4 or 5 days up to 10, 14, it has a positive effect even without any apparent signs or parameters.
ثانك يو. انا بسال برضو بانسيست على ده لان احنا بنشوف لما بنبدا نطبق ده الجراح بيصر على القلب من تحديدا ان هو ستيل لو. وات كان اي دو يعني هنعمل ايه؟ ملهاش حل. بس اتليست فعلا الاسبوعين اللي قبل ان احنا بنغذي كويس العيان بايا كان الروت اوف فيدنج whether oral, nasogastric, even partial parenteral, we are allowed to use this pre-operatively to enhance the nutritional status of patients for better recovery.
Yes, and it does improve outcome. Thank you
very much.